Ticks infected with the pathogens that cause Lyme disease are expanding beyond traditional deep woods, becoming increasingly common in grassy urban gardens and city parks. High-risk geographic zones cover large sections of North America, parts of Central and Northern Europe, and dense regions like the Scottish Highlands. However, most tick bites do not transmit disease. A bite in an asymptomatic patient never warrants a Lyme diagnosis. The definitive clinical threshold for diagnosis and immediate action rests on a single physical sign, the erythema migrans, or EM rash. This expanding skin lesion usually becomes visible anywhere from 1 to 4 weeks after a tick bite, and it typically persists for several weeks. If you visually identify an EM rash, laboratory testing is not required. Ordering serology now delays care and introduces unnecessary variables. Immediate intervention depends entirely on recognizing the visual variations of this rash. Waiting for lab results when an expanding skin lesion is already present contradicts the evidence-based management of early-stage Lyme disease. To diagnose erythema migrans accurately, providers must first separate it from the localized inflammatory reaction caused by the tick bite itself. A standard reaction develops rapidly, usually within 48 hours of the bite. It tends to be hot, itchy, or painful, and recedes quickly. True erythema migrans lesions are not hot, itchy, or painful. Their defining characteristic is a gradual, continuous expansion outward from the site of the bite. These images show the textbook presentation, an expanding erythematous lesion with a distinct central clearing, which creates the recognized bullseye pattern. However, expecting to see this specific central clearing creates a dangerous clinical blind spot. Erythema migrans frequently presents with no central clearing at all, appearing instead as a solid, uniform red plaque. These solid lesions follow the exact same pathogenic expansion timeline. They simply lack the classic target shape. This atypical presentation is especially common in children. Recognizing this confluent redness is crucial to avoid misdiagnosis in pediatric cases. While the classic bullseye does exist, the true clinical hallmark of the disease is the timeline of the expanding margins. Furthermore, presentation is not limited to a solitary site. Early dissemination of the bacteria can cause multiple concurrent EM lesions across the body. Dismissing a diagnosis because the rash lacks a bullseye leads to untreated infections. Visible expansion is the metric that matters. If the patient's skin is clear but they present with specific systemic symptoms, the diagnostic pathway shifts from visual confirmation to a strict laboratory protocol. Neurological flags that warrant immediate investigation include unexplained facial palsy, meningitis, or mononeuritis multiplex. Other systemic indicators include fluctuating inflammatory arthritis, usually in one or a few joints, as well as cardiac conduction blocks or pericarditis. Without a visible rash, the patient's symptom timeline strictly dictates the laboratory sequence. The critical dividing line is the 4-week mark. First, consider patients whose symptoms began less than 4 weeks ago. At this early stage, an antibody response has likely not developed, and serology tests frequently return false negatives. If clinical suspicion is high, start empirical antibiotic treatment immediately. The protocol changes if the patient has experienced symptoms for 4 or more weeks. This duration allows enough time for a measurable antibody response. The protocol here dictates starting with an enzyme-linked immunosorbent assay, or ELISA test. A negative ELISA result does not definitively rule out the infection if clinical indicators remain exceptionally strong. A positive ELISA result requires an immediate reflex to a secondary immunoblot test for confirmation. If that subsequent immunoblot is negative, the provider must pivot to alternative diagnoses or consult an infectious disease specialist. The absence of a skin lesion removes the visual shortcut. Providers must navigate either immediate treatment or a precise 2-tier laboratory sequence based on time. Once a diagnosis is confirmed visually or serologically, pharmacological management follows a specific matrix. This matrix shows how antibiotic drug selection and treatment duration are calculated based on the patient's age and the specific organ systems involved. For oral therapies, patients 9 and older receive doxycycline. Under 9 require amoxicillin. For simple erythema migrans or non-focal symptoms, standard treatment duration is 21 days. Deeper tissue involvement requires extended therapy. Manifestations like Lyme arthritis demand a 28-day regimen. Severe presentations involving the central nervous system or hemodynamically unstable carditis require an immediate escalation in care. These severe cases necessitate 21 days of intravenous ceftriaxone. For older patients, this protocol steps down to oral doxycycline once the acute symptoms resolve. Achieving clinical resolution relies entirely on crossing the patient's age with their specific organ involvement to select the exact appropriate therapy. Let's review this entire clinical pathway as a single interconnected workflow. Visual confirmation of an expanding EM rash is the definitive diagnostic threshold. It bypasses laboratory testing completely, regardless of whether a central clearing of signs are present. The duration of symptoms strictly governs the sequence of the ELISA and immunoblot laboratory tests. From there, the required antibiotic therapy is selected through a rigid calculation of patient age and specific organ involvement. Applying this structured diagnostic logic prevents delayed interventions, halts the progression of the bacteria, and secures the optimal clinical outcome for the patient.